Thank you very much for joining. Already, I think around 47 participants join, and by the time we will start, it will be 100. It's so encouraging. Dr. Gita, thank you very much for covering this important topic. After hearing that how we should handle patients at home in various places, now it's a time that if somebody wants to start a standalone hospice or palliative care setup, how they should handle the situation and what are the principles that will govern a success. So this topic will be dealt by Dr. Gita. We all know, I think, those who are here, but definitely for newcomers, new MDs, Dr. Gita is a very senior palliative care physician as well as pain physician of this country. She is currently, she is former deputy director and professor and head, and I visualize and I can see and I can say that she has really worked hard to start palliative medicine at Gujarat Cancer and Research Institute, and we can see that there it has already started and students have joined. So I think she really worked hard for that. So thank you very much, first of all, Dr. Gita, for working so hard to start MD Palliative Medicine at GCRI. And she has multiple publications in national and international journal with many chapters in book. She was past president of she is past president of South Asian Regional Pain Society, Indian Society of Study of Pain, and also past secretary of Indian Society of Study of Pain, as well as she is trustee and founder member of NGO Unnat called Unnat. She is a governing council member. Beside governing council member, I want to say one thing, that all the work related to, many of the work related to charity commissioner and background work of Indian Association of Palliative Care, Dr. Gita is doing very sincerely and is still keep on doing. And I think because of her, all our paperwork with charity commissioners are in as per order. So thank you very much for that, Dr. Gita. She has received in 2016 Excellence Award for Best Talent University, and also received SARC Country Award for Excellence in Leadership in Palliative Care, which was given by Cancer Risk Society in the year 2017 and 18. So we all are looking forward to listen to you, Dr. Gita, and already now 58 people, and I think very fast people are joining. And thank you very much, Dr. Gita. Please start.
Thank you, Sushma ji, for kind introduction. And it is my honor and privilege to be part of IAPC and work for IAPC. And I'll keep doing it as long as it is possible. Thank you. It is very nice to work with you presently as you being a president. And we are doing many things together. Thank you, everyone. Am I audible?
Yes, you are audible.
Yes,
you are audible, and your slides are also visible.
Yeah. So I am given a topic of practical aspect of starting a new standalone hospice or community palliative care center. In fact, the center at which I am working presently after retirement is a community oncology center. It is and palliative care is part of it. So it is a center for cancer care as well as palliative care. Secondly, it is not standalone. It is very much affiliated to Gujarat Cancer and Research Institute. But since it is 14 kilometers away from the main institute, you can say it is standalone. But for all practical purpose and for all patient-related care, it is part of GCRI. So this is our new building of GCRI, which has come up in last 2 years. And this one is community on our hospice cottages. We'll get to know more about these two institutions in next few slides. So what is freestanding or standalone hospice? It is the hospice which is not within the hospital premises. So if you consider you can say our center is a standalone, but it for all patient transfer and patient care, it is connected to GCRI. Coming to the first slide of my presentation, and where I want to remember the two pioneers who have started this hospice care in India, in western part of our country. In 1987, Dr. L. D'Souza from Mumbai started Shanti Avedan Ashram, and almost at same time, Dr. M.T. Bhatia, my teacher, started our Community Oncology Center, which has got a hospice in the same premises. And with this pioneering work, the hospice movement or palliative care movement started in India. Remembering the pioneers from Western world, everybody knows Gilliban. There was a WHO collaboration that time, and Dr. Venta Frida also visited our campus and our institute. And this is the picture when the second IAPC conference was held at GCRI. Even Gillivan just visited the center just 2 years before, and it was a very nostalgic moment for all of us to be with her for a day or so. So this is how the hospice, our palliative care center, started. That time, Gilliban stayed in our campus for 6 months and trained 4 nurses, and that is how the training in palliative care started at our institute. And then, first of all, when you want to start a hospice, you ask yourself why you need a hospice. So basically, a need assessment survey is required. And in the survey, these are the points one needs to be included. What is the total number of death in the community? And what is the main cause of the death? Where do people die? Do they die in home or in hospital, in a nursing home? Where they wish to die. And all of us knows that most of our patients prefer to wish to die at home. And what is the trajectory of the disease? Whether more of a sudden death or more of a slow declining, slow death or chronic diseases. As all of you know, in present situation where the lifestyle diseases are on rise, NCDs are on rise, there is a more number of patients who are suffering from life-limiting illness, and they are likely to die with a slow progression of the disease. And for this survey, you can involve a community care team if there is some palliative care team working in your area, or any NGOs who are working for such life-limiting illness like cancer, HIV/AIDS. You can also take data from the healthcare setup in your surrounding. So from this, you will be able to identify the needs. So the area in the community where there are very few relatives, most of the younger one generation is out of country, staying out of country, like Kerala in present situation, and almost old people are left alone. And these are the one, this community needs more of a hospice care or a institutional care. And where there are few nursing homes, where there is a poorly developed community services. These are the points to be considered when you are starting hospice. But as far as our palliative care services are concerned, such a need assessment was never done. It was a dream of our director that time and my teacher, Dr. M.T. Bhatia, to start palliative care, and it was started. And since it was affiliated with GCRI, we didn't have much to think about the inflow of the patient to the center. Secondly, you have to, if in present situation, you have to think what type of patients you will be admitting in your hospice. A policy needs to decision. So most of our hospices are for the cancer patients. The two hospices which I mentioned, they are also for cancer patients. But now the time has come when we are likely to get more number of cancer patients as well, and you are likely to treat them in hospice. So in our hospice center also, we are also thinking of starting uh, uh, registering the non-cancer patients as well. Whether your hospice will be for the pediatric patient, whether it will be for the elderly, uh, just excuse me. Sorry for the disturbance. So whether your hospice will be for pediatric patient, whether it will be for elderly, whether it will be for differently able people, these are the types of hospices are present in our Indian setup, like Alpha Palliative Care Hospice, where they treat disabled people also. So you have to take decision. I will say the time has come where we can have short stay hospice. Like patient can be admitted for a short stay of 10 to 14 days for a good symptom control or pain management and empowering the caregivers. After this, patient can be discharged at home. So a very efficient hospice can have a more turnover of the patients, and they can treat more number of patients, and more patients and caregivers will be benefited. So almost we are working on this type of policy where it is must to keep the patient in hospice, then only you get them admitted. Otherwise, you promote home care. That is what. Uh, a case had also come up of the day stay hospice, which had come up in our Jamnagar. It is a city almost 300 kilometers away from here, where one of the NGO had started day stay hospice, but it was not very successful, and now it is no more functioning. So these are the various models of the hospice, various types of the hospice, and you can decide how you are going to admit the patient. Coming to number of beds in the hospice. Before deciding this number of beds, you have to go back to your need assessment, and you can also decide what will be the average length of stay of the patient, your patients in hospice, how many patients die at home, whether you will be there will be supporting OPD services and home care services to your hospice setup. This is very important because most of the patient can be treated by OPD service and by home care service. And our hospice has got both these facilities, uh, uh, supporting facilities with hospice care. And you can also review by number of beds by saying the other hospice palliative care services in your area and how efficient your government programs of palliative care is running in your area. By considering all these points, you can decide number of beds. I will say that a unit which is smaller than 10 beds is not very cost efficient unless it is part of the adjacent unit or a hospital. In city of Ahmedabad, we have a Karunalay hospice run by a trust, and it is 10 beds, but it is part of a trust hospital, so they are able to sustain it. We have good collaboration with that setup also, and presently they are under renovation, so their patients are shifted to our hospice whenever required. But one should always remember there is a huge demand of the palliative care services in our society, in our country, and depending on that, you can decide number of the beds. I have seen Karunashray, almost 75 beds, Sipla Palliative Care Center, almost 50 beds and likely to expand now. And how efficiently they are running. So number of beds should be uh, as efficiently managed. You should be able to manage cost effectively. That is the number you can decide. Our hospice is 20 beds. It was initially started with 10 beds and now each room we are keeping 2 patients, so almost 20 beds. Second is, it is very essential to make it sustainable. You cannot rely on donation all the time. Though donation do pour in, but you should make such a provision that you generate income and make it sustainable. For this purpose, we have this Community Oncology Center and cancer exhibition main building in the same campus. And in this main building, we run many services, which I'll show in next slide. So, to make it sustainable, you can develop it as a few. You can start few partly payable services in hospice, and other payable services which are complementary to your hospice setup, and that is what we are trying to do. So to make it sustainable, main issue is fundraising and how you get the money. A study has been conducted in Uganda, and they have tried to find out from where the finances come for the standalone palliative care service in Uganda. And they have found that 93% of the fund comes from donations, and 7% is from only 7% is from the income generating activities of the hospice. I have seen few income generating activities at other hospice also, but this mere amount cannot make our hospice sustainable. And government of Uganda has a small contribution in form of providing medicine training and payment to the uh, other activities and also things. So they concluded that one has to increase the fundraising capacity and one has to try to get government support as far as possible. In our center also, we have income generating activities, I'll tell you later on. But of course, we do many fundraising programs and donation programs to have a comfortable income to run our premises. So these are various activities which are taken up at the Community Oncology Center, which is in our same premises. We have got, these are complementary. We want to cancer, our center is run by Gujarat Cancer Society, and it punchline is cancer can be cured if detected early. So we have cancer awareness exhibition, we have tobacco cessation awareness programs. Then there is a cancer related health checkup. This is beautiful and very unique program, and it is income generating program as well, where we have various health checkup plans where the cancer screening tests are included. So we promote early detection, we promote screening, and how this is beneficial to our hospice patient also, that also I'll show you in another slide. Then we have community-based early detection camps, training in palliative care for the nursing student and doctors and all, and we get some amount of fees through this training. And in near future, we need to expand to get more income. So this is dialysis. We are about to start dialysis unit. We are about to start partly payable services at hospice, a physiotherapy unit, or and a palliative care chemo ward. These are in pipeline. Dialysis unit is at the top, and it will take a couple of months to start this. So now our hospice is likely to have non-cancer palliative care also, and that is I'm looking forward to have such experience. I'm just going to show you few services of the Community Oncology Center with the pictures. And these services are used for our cancer hospice patient also. See, if a CA breast patient is admitted to hospice, we explain the caregiver, if she is a daughter or sister, we explain them about the importance of screening. We see to it that they get screened every year at our this community oncology center in our health checkup program and all such things. So this is how it is. These are complementary services. We have a huge exhibition on palliative care, on cancer, and one room is given to the palliative care where I have put uh, this type of display panels, and all information about palliative care is given, and which is very useful in training of the nurses and caregivers and patients who are head and neck patient. You know, Gujarat is #1 in head and neck cancer because of the gutka chewing and tobacco chewing. And we promote cancer education and ill effect of tobacco to the caregiver. These are we have this type of hospice cottages, and each cottage can accommodate 4 patients, and we have got 5 cottages and likely to expand in near future. So presently 20 beds, and if we use some extra premises, we can accommodate 22 patients in our hospice. We have a well-placed palliative home care services, and these home care services are provided with the help of Department of Palliative Medicine and as well as our hospice staff, and it covers the whole of Ahmedabad and Gandhinagar city. Training, various trainings are taken up at hospice in collaboration with Department of Palliative Care Medicine. So any training which is planned at the department, these students or participants are posted in hospice for a day or two. So they will have real exposure and hands-on experience of treating cancer patients and hospice patients. Being in palliative care, which is a still upcoming branch in our country, education and training is very important, uh, and it is our responsibility. Whoever is setting up a hospice service or palliative care service or only home based, their main responsibility is to spread awareness, education, and training. And that is what we are doing at our center as well. As I said earlier, through this Community Oncology Center, we have training programs in cancer awareness, tobacco and cancer, screening for common cancer, caregivers training. After I joined, we have taken up this training with 2 NGOs working with us, and it is a really satisfying to train caregivers because they are the one who are going to look after your patient when they are discharged. Then all the courses, as I said, which are run by our department in collaboration, these students are posted in hospice. Recently, community health officers training for the health and uh, family health and wellness center, that is also taken up in our hospice. Last 2 years, we had nurses from Australia under the APLI project, and they train our nurses. It was very encouraging to hold such training. As training and education is responsibility, similarly, to bring your services in limelight for the government is also equally important. So you have to be uh, integrate with the existing healthcare system to make your services visible and to demonstrate how beneficial it is to the patient. So we always try to bring government officials in most of our programs and education programs. In last 3 years, he's Dr. Dolakia, who was Director Medical Services, and he was chief guest for one of our uh, uh, World Hospice Day celebration. Dr. Alok Mathur, who is working very hard to support palliative care at Central Ministry, also visited our campus for one of the training program was a plan for the organized for the NPPC participants. It was very nice of him to be come and boost up our morale. So this is one of the responsibility in which every palliative care center has to do it. After that, to make your services sustainable and visible, one has to do networking. All of us knows network is how important nowadays, whether it is your mobile, whether it is your social relationship or anything, networking is must. And I remember that networking in palliative care was the theme in 2013 conference at Bengaluru. And that time our department was just 2 years old baby. And this helped me a lot in understanding the importance of network and how to establish the network within the premises, within the institution, and outside the institute at state level, at national level, and even at international level. So establish network with it, anything, any healthcare setup surrounding you. After joining this center, I realized we have got a huge number of urban health centers in Ahmedabad, almost 70 of that. If we establish network with them, and which we are doing it successfully, you can get number of patients referred by them, or even they will have uh, they will have confidence. People, staff working in urban health center will have confidence in providing palliative care to their patients. So networking with NGOs, donors, volunteers group, medical institution, nursing school is very important. One thing I have realized, whatever amount of marketing and advertising you do, the most important is marketing is done by word of mouth. She's Archana Rao. She does laughter yoga, and she came to know about our center, and she approached me that I want to do this program for your patients. And since last 2-3 programs she has done in last 3 years. So word of mouth is very important. And that will depend how efficiently you are treating your patient, how nicely you are with the caregiver, and how you are empowering your patient and caregiver. Uh, so networking with other centers in Gujarat, it is very easy as we have a very close group. We have almost 10 to 12 centers across Gujarat. We have formed a IAPC chapter also, and how we are very closely interlinked, very associated, and for the reference system also it has become very sorry, easy. Uh, then and most important is that the staff and doctors from all around the other districts, they come for the training at GCRI and then for a day or two at my center, and that is how we get their contact numbers, and we have a huge directory for that, and we can easily refer the patient to them in whenever a need arises. So this is how the networking is very important when you are starting a stand-alone hospice or a interlink hospice with your institution. Lastly, always learn from others. You need to visit other palliative care services or hospice in India, in your surrounding. But do not try to clone a unit that has impressed you, because your needs, your requirement may be different. Uh, like in our setup, we have tried to accommodate people who are left alone, who throughout their life they are living alone, and they don't have anybody to care. They are living in an ashram or a temple, and suddenly they get cancer and they are thrown out of that institution. Our hospice do take care of them, uh, keep them until they die. So these are the various hospice setups which I have visited. I am in connection with, and it was an opportunity to visit Center for Palliative Care at Dhaka, Bangladesh, and meet Professor Nizamuddin. So learn always. There is a scope for improvement and learning. It is always there in life. These are the few disadvantages of the standalone hospice. But as I said, that ours is a not standalone. We are a team of sharing the care for palliative care with the Department of Palliative Medicine. But many of the standalone hospice are facing problem of getting patients, because still out of ignorance or out of lack of awareness or whatever reasons, primary treating oncologist, primary physician are hesitant to refer the patient to hospice. There are various factors on part of the patient and caregiver also. And in that situation, one has to work very hard for establishing network and promote your center for care of the patients. Now I'll come discuss some general points about the hospice. What are the problems, and what problems are faced by patient once they are out of your care, out of your hospice. Firstly, hospice is not popular in India. And there are various reasons, as I said, that there is a lack of awareness of the concept of hospice, palliative care, and I will say the words itself is difficult to explain to the patient. Then there are no guidance from the medical professionals. As I said, lack of reference, social culture that people will like to take. We also promote home care, but it should be uh, given by a trained caregiver, an empowered caregiver, and who has understood everything about the disease and care of the patient. Uh, these are our hospice data of last 3 years. There is an increase in number of patients getting admitted. The bed occupancy usually remains within 60-70%. Mm, and average length of stay can be 6 months also. As I said, the patients who are thrown out of society or stayed alone throughout the society are also admitted in our hospice till last days of their life. Uh, there are one problem which I am facing in our setup is challenges to deliver end of life care, because we don't have staff in the evening or at night to look after the other aspect of end of life care, like cultural aspect, psychological and psychiatry aspect. And so we need a round the clock team, hospice team, to provide such care. And with 10-20 beds hospice, it is not possible. Sometimes it is not financially viable. So larger than 20 beds, I feel you will be able to provide round the clock services. Are the patients ever discharged from hospice? Yes. As I said earlier, when we empower the caregiver, when the acute symptoms burden is less, pain is managed, they wish to go home, we allow them to go home. Uh, uh, and mainly, these are the patients who will like to go home from outstation, other state. We get patients from Uttar Pradesh also. Patients have children at home to look after. Caretaker cannot take much leave and has to attend the job and all such things. Patient and family realize that it is terminal. Uh, if we tell them it is a terminal, some few patient wants to go away right on the first day or second day, that अभी कुछ नहीं करना है तो घर लेकर जाते हैं. Then we have to teach them about the care of the patient and empower them as early as possible. Non-acceptance of reality, patient's last wish and spiritual needs, and some few people do not like the hospital rules and regulation of getting early and sticking to time schedules and all such things. So these are the various reasons. And we also promote home care. So now the time has come to have a short stay hospice where we should empower the families as early as possible and allow the patient to go home. But the main concern I have realized in our hospice setup, the main concern is patient's problem after discharge. Still, we do not have palliative care services right at the doorstep of the patient. And these are the problems they face after discharge. First and foremost, in Gujarat, we get almost 80% of our hospice patients are head and neck cancer patients. And after going home, the main issue, and they are from very poor background, socio-economic background. And after going home, they don't have access to the good, clean dressing material. We do teach them about the sterilization at home and how to use the other resources and all such things. But still, few of them do come back with the maggots again. Then morphine availability is again an issue, though we have morphine in chemists and dealers in almost big cities of Gujarat. And then people get uh, very much confused where to go when some new symptom starts or pain increases or something new thing happens to the patient. Then emergency symptoms. There is no access to the palliative care, as I said, in their town or at their city where they are living. Financial problem. Many patients do not have good infrastructure or a home to look after their patient. And there is no community support. We don't have a neighborhood network like Kerala in Gujarat to provide the community support. But a step has been taken towards it, and how it is. Let us go through the few slides. So why patients has such problem? Because of lack of this establishing the policy, training, education, morphine availability for the palliative care at the doorstep of the patient. If you go through various healthcare programs and rolled out by Government of India, palliative care is a aspect of all such programs like NPPC, National Program for Healthcare of Elderly, National Health Policy, State Palliative Care Policy. We are working for it, but still we have not finalized. National AIDS Control Program, Tuberculosis Elimination Program, and Ayushman Bharat. The most promising or we are looking forward to well-established health and wellness center and how it will help our patients who are discharged after from the hospice and in the community, how they will be able to get the palliative care services. A well-established health and wellness center, when the patient discharge home, he can approach a CSC or PSC where a community health officer and a doctor of the PSC or CSC can attend the patient. And this community health officer is maybe a BSc nursing student, BSc nurse, past nurse, or a Ayush doctor. So presently, government has taken up the training of CHOs and number of health and wellness center has come up and various training has been started, given also, and where and at CSC level or even PSC, they can have 2 inpatient beds through NPPC program and a facility for the home care one also. So if this program is well established, your patient who is discharged from your institution will have access to palliative care services at home also and at their nearby center. So do we need hospice after that? Still, I will say the answer is yes, because many of your patients will need hospice services for their difficult symptoms, unmanageable pain, and many other social issues. But this program is very promising where your patient will have access to palliative care. These are we have in Gujarat National Palliative Care Program well established in 14 districts. I think next week Dr. Preeti Sangvi is going to have presentation and she will speak more about on what is happening in Gujarat about the various government programs in palliative care. So future, in spite of whether you are having a standalone hospice or you are having a palliative care services as part of an institution, all of us are working towards a future where palliative care services should be available at doorstep of your patient. Morphine should be available wherever they are, and a good home care services for the homebound patients of our palliative care palliative care services. I think I have described whatever is required about my center and how hospice services can be extended up to the doorstep of the patient when they discharge. Thank you very much.
Thank you, Gita Madam, for the wonderful presentation. Really inspiring and a lot of good work. So shall we take the questions and some comments?
Yes, Arun, start comments. Yes.
Okay. So, Gita Madam, the first thing is that about bereavement services. Is there any provision for bereavement services from the hospice or from the center? You have to unmute yourself.
Yeah. Our home care team only provides bereavement services. After a death of patient, we do visit the patient's relative at home if they are in the same city. And if they are at home in another city away from Ahmedabad, we call them on phone. Sometimes they do visit us for some certificate, getting the certificate or some documentation, or giving back their morphine and other medicine. Then also we provide bereavement services at that time.
Okay, and so is this over telephone or like there is in-person visit for bereavement service?
As I said, home care service, home care team provides in-person bereavement services in city of Ahmedabad and Gandhinagar.
Okay, thank you. Ma'am, there is a question like how shall someone wants to work in home care, how to form a team for home care? Any comments on that?
Yeah, for a home care, you can have a separate team or part of your institutional staff can be a part of that team. We have at both the places in department as well as in my center, We have a part of our home staff goes attends a home care, and we keep computerized records for the patients who are in the city, same city, and how they are doing. And with phone follow-up, we establish contact and we provide home care. But so far, we are providing home care to the only patients who are attending our institutions. Very few patients from outside who are not part of our institution or not registered, they also approach, particularly at my center, they approach me personally and we do provide home care to them also.
Okay, so GCRI and also outside GCRI patients can go.
Yeah, GCRI patients as well as few private patients also we provide home care.
And is this like not chargeable? Everything is out of
Yeah,
scope?
it is. This I have forgotten to mention that all these services are absolutely free, complimentary, whether it is a department of GCRI or home care services or our hospice services. These are all free services.
Okay, thank you. There's a next question about.
I'm Dr. Nagaraju from Chennai.
Good morning, doctor.
Good morning. I have two questions, madam. Who are the team members for community-based palliative care? And second question is, what are the legal problems? How to solve the legal problems?
As I said, we don't have community-based palliative care services. Only that through hospice we are approaching community for providing home care, for OPD services and hospice services. And legal aspect, these premises should be registered with the municipal corporation. We should have a proper record system for registering of the death of the patient from your setup as well as from your home care and all. And another is issue of the giving death certificate. If the patient dies in our premises, we do give death certificate, but if they die at home, only we tell them to have contact with their local doctor. When the patient becomes serious, we tell them to establish contact with their local doctor, and he or she provides a death certificate. There are not many other legal aspects in our setup.
Good morning, ma'am. I am Bashir from Kerala.
Yeah.
I want to ask what type of alternatives you have provided or you adopted for home care and as well as the hospice care during the COVID time?
Oh, yeah. It was very challenging during COVID time. When the first lockdown happened, that time we had 14 patients in our hospice, and few of them were from the one of them were from the Uttar Pradesh, one from the Madhya Pradesh, and others were local doctors. So firstly, because of lockdown, we didn't wanted them to get exposed to the outside public. So we closed down the closed down the entry of everybody to the inside the hospice premises from outside, and we didn't allow caregiver and patient or relative to go out the premises. We established a community kitchen, and the caregivers also helped us, and everybody cooked their food for the caregiver also, for the patient also, with the help of our staff, canteen staff, and other contract staff and all such things. And we managed the situation for almost 6 weeks. When the lockdown was lifted up partly, the patients who were from the outside, they were allowed to move out. So till last few months, we were not allowing any outsider to enter the premises. So our patients are protected from the infection point of view. And me and my nursing services, nursing staff continued the providing services during COVID situation also. We never stopped the admission.
Great, great. Thank you, ma'am.
Thank you.
Thank you, Mr. Bashir. So the next question is, are the caregivers allowed to stay in the hospice with the patient?
Yes. Caregiver, 1 or 2 caregivers are allowed to stay depending on from where they are coming. If they are coming from far off places, even 3 caregivers are allowed. And if patient is serious, then more caregivers can come for a few days.
And are their costs being covered by the hospice?
We caregivers are not charged anything, and we have networking with 2 NGOs which are providing lunch and dinner for the caregivers. So patients are given lunch and food and everything from our canteen, and caregivers are given tiffin service from another NGOs. So it is absolutely free, and our people taking our services are from very poor socio-economic background. They don't have money to travel. Also, they don't have money to buy a tea or a biscuit for themselves. And we have various NGOs who help them.
Okay, that is wonderful. Ma'am, there is one question is about the cost effectiveness of hospice care from Dr. Mohan. Any comments on that?
Yeah, as I said, to make it cost effective, there should be some income generating services also. As I said, we have a health checkup program, and now dialysis unit will come up. So some complementary services should be there where you can generate some income. Then as in many other setup, they have patients preparing something and they sell those products. But our patients are very poor, from poor socio-economic background. They don't have much access to such this thing. So it is very difficult. So we are trying to accommodate few services which are complementary to palliative care, like dialysis unit, physiotherapy unit, where we'll be charging from the patient, and this money can be used for the hospice.
Okay, thank you. There are no further questions.
Oh, thank you.
At this point. Sushma Madam, would you like to conclude then?
Okay.
So, Dr. Gita, thank you very
Yeah.
much. It was a wonderful overview and a lot of inspiration. I think those who have joined this class. I know anything we start, it is not a simple thing. A lot of struggle we have to do, and we have witnessed that how much struggle you have done for both for starting MD palliative medicine and coming up with this hospice. And we would like to congratulate you, and we wish that this program which you have started, I know there could not be a unique program. We cannot clone our program to others, definitely, but we can inspire. We take the basic principles that is behind, we should keep that in mind, and then we should try to start our own program the way our whatever our resources, what are our people. So that is what you have done, that you have tried to create your own program, and we will look forward for Dr. Preeti's lecture, that how you have developed and how you have approached, or how you have covered the whole of the Gujarat with this program. So thank you very much, and we would like to really congratulate the way Gujarat palliative care setup is progressing and developing, and it's a teamwork, definitely, and you have created a team, and we are very, very happy for this. Thank you very much, and thank you audience for joining. And I know this is difficult to start at 6:30, but you all are here. Almost more than 90 people are there. So thank you very much, and have a nice week. And we will see you next week at 6:30. Don't forget, on 15th of March, we will not have morning lecture. We will have evening lecture by Dr. Robert Icros. Thanks a lot.
Thank you. Thank you, everyone. Thank you, Arun. And thank you, Nisha, Sushma ji, everyone. Thank you.
Yes, thank you, Arun and Nisha. Definitely. Thanks a lot.